Welcome back. A few minutes lunch. We just want to, before we allow Prof and Dr. N to finalize the session and the today workshop, just want to quickly attend to something that came up during lunch. Lunch is a nice time to discuss and probably pour out your feelings. So during lunch, colleagues indicated their willingness and desire, burning desire to be involved in active projects, where what we have learned this past 2 days could actually be implemented from the beginning to the end. Okay, so we felt that there's no other better way to do that than to get into doing it. And to help us do that, we are going to be asking colleagues on site and online, could you please indicate, if you're online, you can raise your virtual hands. And I would just want to say, it has some terms and conditions. If you're raising your hands to join a working group, if I may call it that, you're just saying I'll be committed to all the sessions, all the meetings I'll be called, and all the actions assigned to me, I will be committed to doing it. And then we will be able to group all those individuals and assign someone who will lead the group who has actually been involved in doing this systematic review some level. So if we do that, we will all be reporting to Prof, okay, and our MRC team. What that means is there will be a virtual meeting. You see, I'm backing you so that I don't see you. There will be a virtual meeting probably once every month, okay? But before that virtual meeting, we'll be able to hand in our timelines and our actions related to that timeline to be reviewed, and then feedback will be provided. And I remember Prof saying within 6 months is doable. So without further ado, because I don't want to use all the time trying to create this group, meanwhile it has a lot of things to tell us. So please, if you want to join in this working group, if I may use that term, please raise your virtual hand or your hand on site so that we can hand those individuals. Prince, can you help me take the numbers, please? Prince, help me take the numbers of those and you can take the names. Please pass a sheet so that they can write their names, please. Please keep your hands so that they can notice you. Okay. Okay. Okay, so from this side, I see it's my 2 colleagues that are not raising their hands so that you know those who get their names. Okay, this side, did I miss anyone? Okay, okay, it's only Dr. Ken. Are you raising your hand? Oh, okay, so this side, I think everyone this side raised their hands. Okay, you're free to change your mind, okay, anytime. Online. Okay, Prof is a tutor, our distinguished professor. Thank you so much, Prof Durant. I think those are the virtual hands I can see. I hope I didn't miss anyone. Sorry? Oh, Lizard. Okay. Thank you. Okay, so those are the 3 online. So let's have the names. Please, Prince and Marilyn, pass the names, and I think you picked up the names online, and then we will randomize it and communicate with us team accordingly. Thank you so much. So keep the mic.
Okay, thanks very much. And being voted onto the executive board of directors. Going forward, we will have an executive meeting about that. But yeah, it is really nice that there is enthusiasm to do it. And the whole idea around the reporting back is if we have a talk on, which we have, but we'll refine the question. The idea is that you spend the next 2-3 weeks refining that question, getting all the inclusion criteria, all the definitions sorted, all of that. so that by the time we get together, we then can go into the next stage of searching. And we work, sort of in concert, so that by the time we finish all the lectures, then your protocol can be done and analysis can be understood. Cool. Okay. So I know it was a bit of a whirlwind trying to get all the concepts and so on. And of course, the recordings will be available to go forward. And now we're going to come to heterogeneity, which I know some of you have already asked, which deals with, how do we make sense of variability across the studies? It's very rare that studies are done in exactly the same way, even if they have the same protocol. One of the places where that does happen reasonably okay would be with laboratory studies, perhaps, where they all have similar machines, they all have the same Astrip machine or whatever, the Coulter counter, Coulter machine, and then they are able to, it's very easy to do analysis across laboratories where a lot of those equipment would be the same. But even then, temperature in the lab differs, the reagents differ, so there's always going to be this variability across studies. And so what we're really going to talk about now is how do we deal with it, how do we make sense of it, and of course recognizing that it's inevitable. It doesn't, again, baby with the bathwater, we don't want to throw it out, but we want to examine and utilize those differences to help us make sense of the data. Okay, just hide. Okay, so now we're really at the stage where we've synthesized the results and we're now presenting the results and trying to make sense of where we go from there. Okay, so heterogeneity is essentially variation in study outcomes between studies. You would expect that if you gave penicillin to children with a sore throat and it prevents rheumatic fever, you would expect that it doesn't matter where in the world you do it, it will have the same result. And yet we know that that's not the case. So that's where the variability comes in. And so the question is, how do we make sense of that, right? Okay, now the question is, how then do studies differ? So we've heard a lot about this, but what would be some of the ways in which they differ? Sample size. Okay, sample size. Any other way that studies would differ? The place. Okay. And the study design. Okay. And the place. Okay, when you say place, you mean variability in geographic area. Okay. And the reason I ask that is because as you mention each of these, it's good to know what effect that will have on the meta-analysis, right, on the overall result. Okay. Any other variability you can think of? Any variation? Is there anything online maybe? Eddie, are you watching the online class? Anything else? Okay. So the variability can also be due to chance. It may just so happen that the results are different. Okay. But then the methods, as was said, okay, so this could be due to the scale that was used to measure the effect, particularly if there's more than one way of doing it. Okay. And then it could be due to the treatment characteristics. So the formulation of the medicine or the formulation of the intervention may not be the same. And again, don't only think clinical. For example, the nature of the SMS as an intervention may differ from one study to another. Or the way that as we say, that you measure pain may differ from one place to another. And then, of course, the patients themselves, which will be things like age, maybe where they live, maybe the education, maybe even the gender or the state of health and so on. And of course, we admit that there are some times when we can't explain the heterogeneity, and that's okay. We can just say we don't know. And then, as was mentioned, the design of the study. Okay, so now here's the important point. When you have this clinical diversity and heterogeneity, where there's variability in essentially the elements of the mnemonic that you're using. So that's the first thing you look for. I see lots of heterogeneity. It is statistically, presented, and I'll show you that in a minute on the forest plot. You look at the mnemonic. The first port of call is the mnemonic. In this case, because it's an intervention study, you will ask about participants' intervention and the outcomes of the comparison group. So that deals with clinical diversity. Then you can also have methodological diversity, which was said. And then the other very important one is the quality of the studies. That will affect how it differs, how one study differs from another. And for that quality, we're referring to the things we spoke about earlier, the various biases, the spread of confounders, and so on. So that all goes into that. Just to say that there are these extensive statistical algorithms that tests for heterogeneity. One of them is called the Cochrane Q test. And it's quite complicated, you can see there, and it's got its advantages and disadvantages. The big thing about the Cochrane Q test is that we no longer use 0.05, we actually use 0.10 as the cutoff point. Okay, so when you look at the p-value, I'll show it in a minute, 0.11 is the cutoff that you're going to have in your mind. Sorry. Okay, then there's another measure called the I-square measure, which also measures the variation across all the studies in the meta-analysis due to heterogeneity against chance. And the I-square produces a percentage where the 100% is maximum heterogeneity, and 25, 50, and 75 are low, moderate, and high. So if you look at the heterogeneity assessment due to the I-square test, and it's around 25%, then you are reasonably happy that there's no statistically significant heterogeneity. It doesn't mean that you must, not use your brain to try and see that they are closely, that the studies are similar. But generally, from a statistical point of view, that I-square test gives us corresponds to low, moderate, high with 25, 50, and 75. Okay, so here's the Robertson paper, which I'm sure now you'll know well. And I just want to get to the point. Okay. Excuse me. And here you can see right at the bottom of the study, it gives us the p-value. And you can see the p-value there is 0.86. Okay? So that p-value is greater than 0.1. So that tells us there's no heterogeneity. So it's significant for heterogeneity if the p-value is less than 0.1. It is greater than 0.1, therefore there's no heterogeneity present. And the way to do it, you can eyeball it actually, is to look at the overall synthesized effect, and you can see the value is 0.2. And so if you were to take from the 0.2 value, you draw a line all the way through the studies. If it touches all the confidence intervals along the way, there's no heterogeneity. Okay, so if you look at this 0.2 value here, you can see the 0.2 value falls within all of these confidence intervals. Right, so the 0.2 is there, you go all the way up, it touches all the confidence intervals, and therefore you know there's no heterogeneity present from a statistical point of view. Okay, so of course, it figures that you may end up with one study that's outside of the eyeballed dotted line, or the p-value will show significance. And that's when you will then think about the reasons for heterogeneity around the mnemonic. So you'll want to then say, tell me, man, is the population in that study different? Or is the way things were measured different? Or is the geographical location or the study design, are those different that may account for or explain the heterogeneity of that particular study? And then in your meta-analysis program, you can now go and leave that one out. So remember in RevMan, you had all the studies that were listed there. You simply untick one of them, the one that's an outlier, and you see what does it do. And oftentimes, the outliers for heterogeneity, when you remove them, the confidence interval becomes very narrow quickly, which gives you then confidence in the comparability of the studies that you included. But you'll see that in a sec. Okay, so is that very clear how the tests for heterogeneity work? There's a p-value, the cutoff is 0.1. You can eyeball it to make sure that the synthesized value at the end passes through the confidence intervals of all the studies incorporated into the meta-analysis. Okay. There's a question, but let me just say, Eddie, you're monitoring the chat, right? Thanks, good. Yeah?
Would you then mention in your video that you had excluded that one?
Yeah, so correct. So what you would normally do in your discussion, and I think I'll have an example, but in your discussion you will say, you'll go through all the various steps of your process. So you will say, we evaluated heterogeneity, and the heterogeneity was 50%. Doing a sensitivity analysis of removing the outliers, narrow the confidence interval, reveal the heterogeneity of 25%. But even doing that, the result didn't change, for example. Yeah, so you would have to make an explanation for that. So in actual fact, all the things that you mentioned in your protocol, remember I said the protocol is future tense. So all the things you mentioned in your protocol, you almost have to address in your systematic review. So for example, you may in your protocol say, if they are missing data, we will contact the authors, or data is not sure, we'll contact the authors. In your result, in your write-up, you will say, even if you didn't, you will say something like, while we intended or anticipated contacting authors for missing data, there was no need because the data was full. Or we made 3 attempts to contact Dr. So-and-so, and we got no feedback, therefore that study was excluded. Occasionally people will also say attempts to obtain the free text were unsuccessful, and so you then have a list of studies awaiting further classification because you're not sure. And then you say, but when we do an update, we will incorporate that study. Or there's a trial on the go, the trial is 80% complete, authors refuse to give us information, but it's flagged for the next time we do an update. So it's that kind of thing, yeah. I know people asked about the update the other day, and what we've actually done, I think Eddie was challenging me about an update. What we've actually done was to give the updates to our students who are looking for dissertations. It's very easy, actually. If you're doing a mini dissertation and you do a systematic review, I mean, that's a breeze, right? The protocol is done already. You have studies that were already incorporated into a systematic review maybe 10 years ago. And now it's time to update. So we're busy updating 1 and 2 reviews at the moment. The SMS vaccination one, Gail just submitted that for MPH. So there's a few. We're going to update the adolescent one. You may want to join that one with the standardized mean difference with the parents with children with mental disabilities. Amir is doing that. So you could join that if you want to learn from Amir. We're going to update that one soon, or you could do it. Paper. So we do some updates, yeah. And sometimes because the studies weren't available at the time, we kept it open. On the missing data and getting hold of papers that you can't find, I don't know if your library will find it for you. Do they do it for you? The cost, do they charge you?
No.
Oh, okay. At Cape Town, we have to pay sometimes, depending. But you can also write to the author. Go to ResearchGate, write to the authors there. And they often will, they only too happy to have their paper going to a systematic as a citation. So they often send the paper to you. And then there is a site that you shouldn't use. You won't use it. I can't say the name, but it has its origin in certain place. And they believe that all research must be free. And so they'll take a paper, scan it in and put it on there. Yeah. So there are places to do it. I'm just scared to do it because they're going to hack my computer. But yeah, so there are places where you can get papers. And sometimes your supervisors have enough money, they can just pay for it. It's $20, $30. You get a day's access, and then you just download every article that you see. Another thing that's also worth mentioning is that when you're doing the searches and when we do the ongoing collaboration, you'll learn about these, that there are many sources. It's not only PubMed, Scopus, Web of Science, particularly if you're desperate, like you really want to get all the data like I was. And so there are these catalog of theses that are available. It's called WorldCat. And you can probably get it through your library here, but certainly through UCT's library. And they publish PDFs of almost every thesis that has been produced in different parts of the world. So you can go into Harvard's catalog of theses and you'll see stuff there. If you've done a thesis already, put in your own name and see if it comes up. It's quite cool. And then at UCT, the theses are held on an open server, and they actually then tell you how many times people accessed your thesis. And it's quite cool. A lot of people, and from where in the world they looked at it. I people from like South America, everywhere looking at my thesis, which is quite cool. And so you want to incorporate theses data also in. You will do critical appraisal of that because it needs critical appraisal. And then you can make a decision whether or not you want to include the peer print servers. So that's MedArchive and BioArchive. Those are a nightmare to work through, difficult to navigate, no real search engine available, takes forever. So you may want to do that. And then like in COVID, because we were wanting to get every scrap of information that we can, we even included, like it's called ProQuest. So you can get Twitter feeds, you can get all that other stuff as well. So the bottom line is the search is much more extensive than PubMed or what we've shown you, if you really want to get all those articles. Yeah. And as I say, you are doing it anyway, you may as well just do it properly. But provided you state the limitations of your search, and that's fine. So if you say we only search these three, then that's fine. When Ardell did I mention about the Violence Observatory, right? Did I tell you guys about that? Yeah. But when we did Ardell's one, a lot of the articles were in Spanish. And somebody was asking about collaboration, right? And so what I did was I wrote to a professor, I hope she was Spanish at the time, Spanish speaking, and she was. I mean, her name sort of gave it away. And I wrote to her, she was in New Mexico in the US, and she had published a systematic review related to the topic. And I wrote to her, Maria Cortez was her name, I think. And I just said, dear Prof, we're doing a systematic review. We need a Spanish-speaking reviewer. How about it? Wrote back, said, sure. And because a lot of the articles on violence came from South America, from Colombia and other places. And so she was our collaborator. They did all the Spanish articles. We found them on Lilacs, a different database, found them, sent her the list. They just did all the data extraction, sent it us with a joint publication. So there are ways around that too. But you want to get as much information as possible. You don't just search in the main ones. And then the other place that's also worth looking is the proceedings from conferences. So if you're doing HIV, you may want to go to the HIV World Congress that happens every 2 years or whatever it is, and look at the abstracts on there. You can search the abstracts for rheumatic heart disease, the World Heart Federation, we search the abstracts there. There's a couple of places you can search abstracts as well. Because the truth of the matter is abstracts often contain valuable data. And then, like if somebody wins a lotto, they don't publish. But those data are available. When I did my systematic review, I found data from conferences, and they were included. And then they have limitations. When you critically appraise it, you can't do, I don't know, selection bias, because they didn't say exactly what just came out, and that's okay. Cool. Thanks for that question and interaction. Okay. Now, you will see on top here, it speaks about fixed effects, and then there's also random effects. And that basically refers to the model that is employed statistically in generating the meta-analysis. So the fixed effects model, it never came up, but the fixed effects model assumes that the studies are measuring the same underlying effect and that the variability between the studies is exclusively due to chance. So this would be your laboratory-based studies. They're measured in exactly the same way. They have the same reagents that were used. They have the same Coulter machine or Astrid machine, whatever. They did it exactly the same way. The studies are so similar that you can use the fixed effects model. And in the statistical sort of algorithm, the studies are weighted according to the inverse of the within study variance. And the problem with it is that it often overestimates precision. In other words, the confidence interval is often smaller or narrower than if you use the random effects model. Okay, so with a random effects model, the assumption there is that it's a random sample from the universe of possible treatment effects. And the bottom line is the confidence interval is wider than the fixed effects model, but there is a downside that small studies get more weight than they should. When I started out in systematic reviews and meta-analysis, the biostatistician told us, always assume that there's so much variability that you can't account for it, therefore use the random effects model. Now, because the random effects confidence interval is rather wide, it basically says if you get an effect with a wide confidence interval, you are confident that that effect is real. Whereas if you get an effect with a narrower confidence interval using fixed effects, you are not sure, had you done random, would it have worked? And it's very interesting when you look at some papers, the authors don't tell you that they use fixed or random. You see it in the meta-analysis there. And you'll see they use the fixed effects model where it's very close to statistical significance, because if they use the random one, it wouldn't have been. So they sort of play tricks with you. But generally, you look for random effects. Now, all of the things I've told you means that you are now able to critically evaluate a systematic review. So if you see a systematic review for your clinical practice maybe, and you as a new treatment option or something, and you want to know if the systematic review can be believed, you know what questions to ask. You're going to ask, was it independently data extracted? Where was the search done? Was the search complete, extensive? You're going to ask, was it done in duplicate? Was there an arbitrator? You're going to ask how the data were extracted. You're going to ask what was the critical appraisal tool used. You're going to ask, was there heterogeneity and how did they deal with it? So everything you've heard over the 2 days is putting you in a good space to be able to critically appraise a systematic review. Whether it is for your clinical practice or practice in general, or whether it is to justify doing another review. So oftentimes, a student will say, I want to do this review, and then we look and it's already been done. But then what we do is we go to that review and we check it for all of these things to see, was it done properly? Was the search extensive? Was the inclusion criteria the same, etc.? And we come away with a paragraph in the thesis that says something like, a recent review on the same topic was done. However, that study failed to include XYZ, that study did not include critical appraisal, blah, blah, blah. In other words, basically the study was done in a bad way. Therefore, or since then, there were lots of new papers that were produced, or lots more studies in the African region, and that's our interest. Therefore, we undertook this systematic review to provide an evidence-based estimate of the prevalence of whatever. Okay, so there are ways around it. Obviously, it was beautifully done, fully executed, up to date, published last week. It's going to be difficult to make a case for doing the same one. Okay. Okay, so if you get a test for heterogeneity, that's not significant, you don't have to worry, but you always want to explore heterogeneity. And so you can, of course, then explore various subgroups and so on, as I've said. Okay. Now, the big thing with subgroup analyses is that they must actually be decided before the time. And they, especially if you have a protocol, oftentimes the examiner or the reviewer will go actually look at your protocol to see what did you say you were going to do, and then evaluate whether you're doing it or not. But if you are just doing it after the fact, it's akin, as they say, to data dredging. It's trying to find some kind of association where there may not be one. Yeah. Okay, and so of course you would then put it all into your protocol before the time. So here, for example, is an analysis by zodiacal breakdown of the people arrested in the area in 2011. And you can see Aries, I'm not sure what one you are. Aries had the most crimes, they committed the most crimes. Okay. I don't know which one you are. I'm not too bad here. But the point of this slide is, so just by the way, I don't believe in the same. It's actually quite ridiculous. I was at we got the planetarium in Cape Town. You got it here, planetarium? Anyway, we've got a planetarium in Cape Town. And, you lie in those seats and then you look up at the night sky and whatever. And then the guy asked for your birthday. And, he's nobody shouts at, of course, to the embarrassment of my children, I shut mine up. And then the guy takes the sky, it's actually quite cool. He turns the sky back to the night I was born, the day I was born. It was so cool. And then he then says, okay, this date, at this time, and he says, oh yeah, at that point you were, I think a Gemini or something else, which is what I'm not now. And then, of course, I cooked up, so my personality changed. Right? Anyway, just saying how ridiculous it is. But this illustrates the point that if you really dredge the data, you're going to find a result. And that's what we don't do. The difference with systematic reviews is that you know ahead of time exactly what it is that you're going to be looking for and how you're going to analyze it and how you're going to present it. And you know what's so cool about that is that it frees you. You know, like that concept that true freedom must have a boundary? Because if you don't know where the boundary is, you don't know what freedom is, right? And this is what happens by having the protocol. It just frees you. So if you don't find what you had intended to find, you simply say it's not there. You don't have to go and do all this ridiculous analysis to try and make some sense of it. It's not there. We intended to look at whether or not urban status has a difference on outcome. And then we looked, we didn't find it. Or we looked, there were no data available, therefore we cannot report it. And you know what the beauty of that is? That at the end of your systematic review, the two most important paragraphs in the conclusion are as follows. The one paragraph is, what is the implication of this review for clinical practice or for practice? So it would say something like, this review found evidence to support the use of the fancy pillow to prevent snoring, for example. So that's the implications of this result. The other paragraph that is equally important is implications for research. So this review found a dearth of data on whether or not the type of pillow affects snoring. Therefore, the authors humbly recommend that future studies include a component of pillow type, pillow height, whatever, and snoring and decibel monitoring, whatever, for future studies. So now what happens is, when somebody is about to do the study, they're going to read your study, and they're going to say, oh my, here are the recommendations. These folks have practically given us the protocol. And then your particular paper will be cited forever. So so don't think of systematic reviews, or don't get defeated before you start, is the point I'm making. Oh no, I'm not going to find anything, I looked and there's nothing. That is the wrong point. What you're trying to say is whether or not it works. So an example that Edison was alluding to was done by somebody called Liesel Grobler. So you know, remember when, some of you don't, but there was a time when doctors weren't wanting to go to the rural areas to do their community service. The doctors want to go now? No. Okay, so there's two sides to that anyway, but so doctors didn't want to go. So what did the government do at the time? They gave a rural allowance, right? How much is it, like 35% or something?
No.
So less now.
Well, it's of your base salary.
Yes.
But overall, it's like less than 8,000 rand, which is not that significant when you compare it to
Okay.
there. But I mean, if you.
Your 8,000 rand significant.
It's very significant.
But I mean.
Obviously, it's not significant.
But if you have to book how many flights and
That's true.
have
Yeah,
like 3 hours to get booked,
Yeah, no.
and like not have water and
No, no.
not have lipstick.
Did you go somewhere?
Yeah, I went to like above Transkei, above Aituchwa, the Mobile.
But look at you.
But
You were a semblance of health and vitality. You must have done something. Maybe you found your wife there or something.
no, I was with my wife. So
Oh, okay. So you each got 8,000. Anyway, the point being, when they were thinking, thanks for sharing, and you're not putting it there, as they were thinking about this, they decided to do the financial incentive. And I think it was something like, it was going to be 30%, I stand corrected, at the time. Because I know a lot of people went. And I know a husband and wife couple like you that went to like the northern part of KwaZulu-Natal, under the Drakensberg, and all they did was canoe and horse ride, man. I mean, they worked, but their weekends were spent with a 2-man tent, climbing here, climbing there, and so on. Anyway, just because something's a good idea doesn't mean it works, right? So Liesel Grobler decided, to do a systematic review on interventions to improve doctors' uptake of rural community service. She wanted to know if it works. Spent a lot of time doing it, and guess what? There wasn't a single study done. So in other words, the rural allowance that was proposed was done merely on someone's whim. Oh yeah, let's give them money, they'll go. Whereas a proper study would have said, what are the factors that would influence doctors going first? And then say, let's develop an intervention based on that result. So if doctors then said, no, I would like to go if you deliver Woolworths food parcels to me every month, then I'll go. For example, I know someone who's in a similar situation where they are 4 hours away from Woolworths. So there's about 4 doctors. And so they then, like, I think once every 2 weeks, that someone's turn to drive the 4 hours, maybe it's a return trip of 4 hours, to go and fetch the supply. So they come back like with a truckload of Woolworths foods, pre-packed, I suppose, yeah. Anyway, the point being that she did that review and she found nothing. So what do you then do? Do you become dejected and say, I'll never do a review again? Of course not. She published the review with those recommendations of implications for practice, implications for research. That review got published, and now people reference that when they're about to look at interventions to improve outcome. So don't get, despondent. If you have your idea, nobody does it, there's no papers out there, it's not going to be a waste. It will still have value. The other thing that I must also tell you is that sometimes you intend to look at randomized controlled trials and you find none. So Jimmy Volning and Nandi Siegfried looked at interventions to prevent circumcision as an intervention to prevent HIV transmission. They were looking at randomized controlled trials. When they did it the first time, they found none. But their protocol said, should we not find any RCTs, we will do a narrative review of cohort studies. So a narrative review means you won't include meta-analysis, etc., etc. And so that's what they did. Sometimes studies can't be synthesized and you almost do just an appraisee report of all the studies. But they published it, recommending that randomized controlled trials must be done. And within about 3 years, they published a systematic review of randomized controlled trials that were done, often many of them with the parameters that Nandi and Jimmy had wanted to be included to make the studies comparable. So yeah, so don't get this one, okay? Now, the cool thing about meta-analyses is that by doing that subgroup analysis, you can see here how you can then look at the effect of study design. Okay? So this is real data actually on vitamin C, I think it is, on cardiovascular mortality. Okay? And you can see there that with the cohort studies, there was a reduced mortality, but in randomized controlled trials, it was actually harmful. Can anybody explain why taking vitamins why you would have this difference? Taking vitamins reduces your risk of cardiovascular disease in cohort studies, but in trials, hopefully randomized, allocation, concealment, etc., they did worse. What do you think is going on there?
Someone who's taking vitamin supplements is obviously conscientious of their health and therefore might be generally living a healthier lifestyle and have.
Aren't you just so perfect? Yeah, that's exactly right. Yeah. So it's exactly right. So the people who are taking vitamins, so in a cohort study, people self-select to take the vitamins, and therefore they are more conscious of their health. And like you're not going to see vitamin adverts outside KFC. Okay, you're going to see it at Virgin Active maybe. And so yeah, you're right. So because they self-select, they actually, this is real data actually, they do better. And then in the trials, they do worse. So this is the example I was saying where people will say, yeah, but they're all smokers and they're already going to die anyway. But that's irrespective of, that may be true, but the controls and the intervention group consisted of the same people. And so the only difference between them was in a blinded fashion getting the intervention. So this is real data. So in this case, taking the multivitamin was actually harmful. And I actually have a colleague whose husband overdosed on vitamin A. He died, and his skin was orange. And he passed away from liver damage after about 10 years or something. Yeah, it was very sad. She was a young bride. They were married for about 10 years or so. Yeah. No children. Okay, so the point being here that meta-analysis helps you to visually be able to see the difference and the effect of, for example, in this case, of study design. So it's very powerful in that sense. Yeah. This is the example of the forest plots on during COVID, and you can see there. Those are my notes there. That first study, the large study, showed no difference. And then you have these smaller studies that had wide confidence intervals, as you can see here. And then the combined effect showed that it was statistically significant in observational studies to favor ivermectin. And then they did do some randomized control trials which showed that it was effective. But look at all the zeros here. See, the numbers are very small. You're comparing 0 out of 183 with 3 out of 180. And you saw that, those numbers start to make you worry when you have such small numbers. For example, there was no indication of heterogeneity, publication bias was not mentioned, and so on. The point being that, that systematic review mindset helps you to analyze these a bit more closely. Okay, so here's an example of a systematic review looking at cooling the brain to improve outcome after traumatic brain injury. Okay? Full systematic review. Only 2 authors, which I'm not worrying, but anyway. So they undertook the study, and those were their specific questions there. Does PTH improve survival? Does it improve subsequent neurological function? And is it safe? Okay. And here you can see they had, I think, about 17 studies that they looked at. You can see, as you can expect with TBI, they're all small studies, 10, 11, and so on. And those studies on their own had wide confidence intervals. If there's an arrow, that means the confidence interval goes even beyond the picture. And so you can see there are a number of studies that are wide confidence interval. They're very small, 5 in them, and so on. And there are 1 or 2 larger studies as well. Okay? And so they looked at the risk ratio. So what is the likelihood of death in the hypothermia group versus the normothermia group? And those are the values of the confidence intervals. Okay. You'll also notice the I-square value at the bottom is 26. That's around the 25% mark. So that's low heterogeneity. And you can see the p-value is 0.15. So that's above 0.1. Therefore, there's no major statistical significance differences between them. And if you were to draw an imaginary line from the diamond all the way up, it would pass almost all, it would go through all of the confidence intervals except maybe this one here. Okay? So the visual inspection of the forest plot using the dotted line from the diamond confirms the heterogeneity is low, with a p-score greater than 0.1 and an I-square around 25. Okay? Now, if you look at the meta-analysis across all of these studies, risk of 1 means no difference, less than 1 favors the intervention, greater than 1 favors the control. You will see that the combined effect comes out at 0.84. The risk is 0.84. Okay? So it's a 16% reduction to our rural doctor. 16% reduction or 84% of the risk compared to the control. Okay. You'll also notice they're statistically significant. That's our important one. So as it stands here, from a pure statistical point of view, this is a significant result. It lays the basis for using hypothermia. Okay. So this is the meta-analysis, forest plot, of all the studies. Based on what we spoke about earlier, what are some, and here's no heterogeneity here though, what are some of the things that you'd still be wondering about before you believe this result? Seriously, not rocket science. We've discussed all of them. So what would you be worried about? Whether, what is the same?
Sample.
What about the sample? Being the same?
Sample selection, so ages.
Ages of the patients you may be worried about. And the injury, nature of the injury, yeah, the extent maybe of the injury. Anything else you're worried about? Okay, the time delay, yeah, okay, after the injury. Okay, anything else? Please make my heart delayed.
Are these all randomized controlled trials? or-
They're all randomized control trials, even though some of them are small. Anything else? Oh, my God, Glenn, yeah.
You see, that was the risk measure was in the, the chance is not far away. That
Yes, they have a reduced risk of dying of 8.84. Yeah, but across the studies, whatever, yeah.
I also wonder about what was the impact, about how much damage there was left for those that was still alive. How much more damage there was still.
Okay, so that's a secondary, that will be part of the secondary outcome. But just in terms of the primary outcome of mortality and whether or not this intervention works, what else would you be worried about across these studies? That they are all the same with respect to the intervention, okay? And yes, they're all the same. What else?
Severity of the disease.
Severity of the that's what's said, severity of the lesion.
How do you define hypothermia?
Hypothermia, so the nature of the intervention. What else? Oh, please, come on.
Six,
The nature of the participants. Yeah. One more. The what? Okay, the extent of observation afterwards, yeah. But there's one more. One very obvious thing. The quality of the study. No? All the other stuff is true, but the quality of the study is what you're worried about. Okay. And when we talk about quality, randomized control trial, we're talking about, you sort of mentioned selection bias and all of that, right? So then, when you look at the quality of the studies, there were only 3 studies that had a high quality score. There were 3 studies that had a low risk of bias. And no surprise, when you look at those 3 studies alone, even although they used fixed year to be a bit scallop, they wanted to make it as narrow as possible, it still was not statistically significant. So you were asking earlier about how do we use critical appraisal, where do we discuss it in our discussion on that. This is how we use it. So we have the overall result, and then we say we did a subgroup analysis of the studies of high quality only to see what the result, if the result was consistent. And we see here that between these 2, the result is not consistent when the low quality studies are. Okay, that's the same one, yeah. Okay, I'm going to end there, it's now 3 o'clock. We got time for questions. I think our transport's taking us at about 1:15. So we have questions. I don't know if there's anything else you want to see. I've got one more thing that I promised to show is the qualitative synthesis. I'll do that in a sec, but are there any questions around heterogeneity? Any comments? Even about the whole course? Seriously, we got broad shoulders. Eddie is more broad than mine. Is there things that could have been done differently, better? And I'm not fishing for compliments. I seriously, if there are comments, I would like to know. Yeah.
Just a question on that last example that you showed.
Yeah.
So obviously they have the many studies and it looks great. And then when they do this bit, it shows that it's not significant. So when they write it up, what would you then put as your final conclusion?
Yeah, so that's a good point. So the question is, given the fact that heterogeneity sort of jippers the results one way or another, how do you actually report, for example, in your abstract, the conclusion? And you would say exactly what you found. So this review found from high quality studies, no evidence for the effectiveness of therapeutic hypothermia on mortality versus control. Okay. In the discussion, you would have put, a broad overview, meta-analysis showed, but when we went a bit closer, we realized it wasn't effective. Yeah. Because remember, people are going to take these results and make decisions on it. These kind of reviews are going to be used in clinical guidelines around the world. And then they are going to do a systematic review, critical appraisal of your review. And so they're going to see, was it done independently, were the definitions right, blah, blah, blah. They're going to do all of that on your review. And it's actually quite scary. I think we gave a review that we had done to the students to critically appraise them. It was scary. Like, you think you're doing it perfectly, but there's always stuff you don't see.
I think what's scarier is the fact that those decisions are made based on this. And if you don't really understand it, like no one makes you, like not forced to actually understand it like this.
Sure. Yeah.
And you think you're doing it based on good evidence, but you can make it look like good evidence.
Yeah, no, that's a one moment, which is really comforting to me, thank you. And the truth of the matter is that clinical guideline committees often are not constituted with proper methodologists. So Amir and I were part, as I told you, of the COVID one, and that was just published recently, quite cool, see your name in the lights. But I was asked to help another guideline group with their systematic, they said, oh yeah, they really like at meeting 6 and one of the societies in South Africa, they're doing the guideline, they cannot join and all that. I was there for a couple of meetings, gave them some training on RAAM, set up all the RAAM for them, and then it was too much of a hurdle for me. There are times when I'm just like, I can't put my name to something that's not done for me. So I gave all the advice and I gave it very willingly, and they promised to pay us and they never, but that's okay. And like lots of money, man. More than 8,000. And yeah, so the guidelines, some of the guidelines are a bit scary. And it's very interesting. I mean, I shared personally about our journey now with Jan, and it's very interesting to read how the recommendations go, even for osteoporosis, where the meds have long-term effects. Anyway, we found a doctor who publishes in PubMed, not somebody who has a fancy practice with his Maserati parked outside. And he's going to be attending to it. And so cool, like just his answers were the right questions, which as you read the Cochrane reviews, those are the questions that doctors should be asking. And he asked all of those in an email. In actually, he was one of the few people that bothered to answer. So you're right, guidelines, it's scary that people are not using these. And if you go and look, for example, at the South African Rheumatic Heart Disease Guideline, scary stuff. It was written by 1 or 2 people, 1990 or something. Since then, we've had echo diagnoses, we've had all kinds of stuff happen. Not included, not incorporated, not upgraded. So, yeah, you've got a whole career ahead of you here, man. Okay, any other comments? Yeah, there's one at the back. Yeah, go for it.
For my question is, we've done the first course, but I've seen that that is like the sort of own design of clothes. And so how do you go with it?
Okay, sorry, I should have mentioned that actually. That's is analysis of publication bias. So, this is a lecture on itself, but basically, the result is plotted against the standard deviation or the standard error, and in such a way that the larger studies and the smaller studies together form a funnel. And if parts of the funnel are missing, essentially, you are saying that there are studies that you are missing, studies that you haven't found, or studies that should have been published to help you, give you more assurance that you found all the studies there. So basically, remember I had a slide about publication bias and about how some results are not published because they're not statistically significant. And one would expect that those studies, they should have been published. And there are some journals, I think there's one journal that does studies of negative results, so that you can see what doesn't work. Because if you don't tell me, I mean, there's a cartoon there that I throw in my talks with funnel plots. But there's a young man, he arrives at the prison, very excited, he's going to escape. Oh no, it's going to be easy. He escapes, he gets caught, brought back. He thinks, oh no, I must change my plan. Tries again, escapes, gets caught, comes back. He does it 3 or 4 times. Eventually, he's sitting in the yard with an old gentleman and he says to him, have you ever tried to escape? And the guy says, yeah, many times. So he says, why many times? He says, no one's interested in negative results. Okay, so the point here is that those negative results or the non-statistically significant results are still important because they then tell you that, you know, there's either no point in doing it or there's still a lot of work to be done. And so final plots are a way of ascertaining the range of the population. I can give a little talk on that. I've got a nice easy paper that explains it. Yeah. That's a good point. Thanks for bringing that. Okay, any other questions? I'm just going to show a qualitative systematic review. And sadly, Sarah is not online today. She's not well. But she's an expert. She literally writes the methods for Cochrane as well. So should I get another league? Actually, can I get onto the internet with this? Let me just see. Okay. So I'm just going to show this PDF. Yeah. Cool. Back to Zoom. Okay, so this was a study that was done by Sala in our department at the time. And as you know, qualitative research tackles questions about lived experiences of patients or participants, either in receiving an intervention or the experience of living with the disease and so on. And at the time, you'll remember that with TB, they had a program called DOTS. You remember DOTS? Directly Observed Therapy Short Course. And they showed that DOTS was a disaster. As much as again it's a good idea, you need to test whether it works. And so there were lots of things about, they just showed it didn't work. So now the question is, what about DOTS didn't work? And this is where the qualitative researchers come in. They are able to then dig a bit deeper. Instead of you, as a quantitative researcher, saying, tick the box, yes, no, you are now allowing your participants to speak from within. So I think it's called inductive sort of, research. They speak from within. You don't guide them. You don't guide their thinking. I think you just let them share what they are feeling. And so what Sala wanted to do was a qualitative synthesis of all the qualitative papers around patient adherence. Okay? And so very much like with what we've been talking about, we searched databases and for qualitative studies, and you can see here we had keywords, TB, we spoke about adherence or compliance or concordance, those are the alternative terms. And then we supplemented the citation searches by checking experts and going through reference lists and so on. At that time, we got 7,814 citations, and from those, we selected 44 articles. I'm telling you, this is very different to doing quantitative research. 44 articles in qualitative synthesis is like 5,000 quantitative ones. Man, it was long to read. Anyway, they met the pre-specified inclusion criteria and so on and so on. And then our interpretation of the themes across all the studies produced a line of argument describing how 4 major factors interact to affect adherence to TB. So when we started this, we had no idea how many major themes would come out. We had no idea what people were going to say. We just wanted to extract from those data, from those papers, the data that would speak to us as well. Okay? And so those 4 factors were structural factors, poverty, gender, discrimination, social context, health factors, personal factors, and so on. Okay, so that's how we did it. So in the same way, you're going to have your prisoner chart. Okay, so this was the method as to how we're going to do it, the process, and there will be a chart later on. Okay, here's the chart. So there were 19 databases. We identified that many blah, 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 excluded, and we ended up with 44. And then the methods have changed a lot, but we also did quality assessment of all the studies. So there's critical appraisal using a peer-reviewed tool. And then from that, the synthesis now is no longer numbers, numerator, denominator. The synthesis now is to identify the themes and concepts. That was hard work. If you're not a qualitative researcher, you read these things and it's like, whoa, like what theme? And especially when the person's going, oh, yes, can you just see the theme? And I'm like, oh, but due respect to my non-recording death. Anyway, so here's an idea of the qualitative, the quality that was used. So these were the leading questions there that you can see, that you ask. And then from there, we had to obviously synthesize everything together. And then from that emerged these primary and secondary themes. And in a way, sure, it requires quite a bit of a brain to decide what are the themes coming out. You have some idea what those key thoughts are, and there's sort of some idea of a canned text approach. But you really, that takes quite a bit of reading to get there. But anyway, so we did it, and then from there we came up with our themes. So you do the same thing, characteristics of the studies included, and then you also include some quotes to support some of the themes, and so on. So that would be, I've got a protocol for you, Beth, on this. And then you have these boxes where you just highlight some of the various things. But I must say, like I told you about the rheumatic heart disease one, where the qualitative study showed why people don't go for adherence. And it's so easy to overlook those. So even now, we're thinking of doing a qualitative study around knowledge translation and plain language summaries, trying to understand what are the factors that will promote or facilitate people engaging with plain language summaries and so on. So in a nutshell, but I'll give you more detail. And Sarah, actually there's a lecture that I can actually post as well. I posted the webinar for the prevalence. I sent it right on Zoom. It's on Zoom. I did post it, but I'll send it to you anyway. On the prevalence webinar using R software. And then we've got one that Sarah did on qualitative evidence synthesis as well. Well, I'm going to stop there. I don't know if there are any other questions or comments.
Any questions or comments?
Question online.
Okay. Okay, doesn't matter. Thank you for this morning's workshop. Here's the link. Okay, that's the one I sent, your online email address. using a fixed effect. Oh, so to ML bar using a fixed effect, not randomized. So the two sides of that coin are fixed effects versus random effects modeling, not to be confused with randomization. The test for the overall effect, I take it you're referring to the bottom of the forest plot. We don't really use that, but it is a measure of the significance, as far as I remember, of the effect. But we don't use that. We rather use the confidence interval to give us an understanding of the significance of the effect. And then, thank you, most informative, thank you, that's very kind. Yeah. Okay. Thank you, Paula. I'm going to end there.
Any more questions or comments? All right.
Just to add something, Cochrane South Africa, we have YouTube channel where the webinars on the bias.
Yeah, so that's the one I shared earlier. Yeah. And then you just let Benny know that you want to go on I gave his email address, let him know that you want to go onto the mailing list, and I'll give it to Paula as well, then we can let you have that.
There's a last comment there if you want to read it.
The last comment.
5, 3 or 5.
Can I read it?
I don't have the microphone.
Which one are you referring to? Is it a question or a comment?
A comment.
You don't have to read everything.
I want to read this so that we see what the prof actually knows why he's not on it. It says, thank you, most informative workshop. I enjoyed the structural approach of systematic review and meta-analysis. Looking forward to the next informative and interactive session.
That's enough.
Thank you so much. Can you please just every day of this? Prof is quite busy tomorrow. He's already on his way somewhere else, but he factored, these 2 days really kept it aside for us. We've been corresponding over the months, trying to get this started. But I'm glad this has happened. Thank you very much. It's my joy to welcome one of the ESCO committee members of the Faculty of Health Sciences, a distinguished professor and the director of the School of Clinical and Medicinal Sciences, in the person of Professor Truta Issa, to do the closing remarks for us. Professor Truta Issa, are you please online? Thank you so much.
Thank you, Prof. Paula. Prof. Mark and Edison, a big thank you from all of us. And I think I'm talking on behalf of everybody online and also in person. These days it is difficult to ignite little fires in people. And I think from yesterday morning until now, you have ignited a lot of little fires in us. This was high quality. It was fast-paced, but it was also informative. You are giving us enough. I think all of us have homework to do. I went back. I'm at the age where it's a difficult time period if you reach this geriatric age. So I was looking back in my CV just now, and on the 27th September 2001, my research unit hosted a one-day workshop entitled Evidence-Based Healthcare and the Cochrane Collaboration. So we had the MRC in 2001. I think some of the members in the audience may not have been born yet then. So and then in 2006, there was also in collaboration with the Cochrane Center an ECRU, Effective Care Research Unit, randomized research methods course in 2006. And those are the two courses that I've attended. So this was time for an update. I think we've learned so much. I thank you that there will be a continuous interaction. From what I've learned is that we can virtually connect. There's a lot of information has been shared with us in a very systematic way. I think it was easy to follow. For us, it was packaged very nicely, and yes, I think we've got homework. We now need to put pen to paper and start, or fingers to keyboard, should I say, and start working, because we want to increase our research outputs in the faculty. And I think this is an amazing way for any postgrad student also who is doing literature study for their master's or PhD. This is invaluable. So a big thank you from all of us to our two presenters, also to Prof. Paula for organizing it, Bertolin, and also the team around her. We appreciate all of you and the efforts, and yes, may there be many more publications from our faculty coming forth. Thank you so much from all of us. Thank you.
Thank you so much, Alex. You don't need to sit for me to dissolve the session because it's not a convocation, but please thank you so much. And we are going to be meeting hereafter virtually and as time will permit. Once again, please thank you and extend our well wishes to your bosses that allowed you to take up these 2 days. And please do enjoy the rest of the evening. Thank you.